Well, this one I think maybe I'll turn to Aditya for, is that this comment was given that AIs don't really work well in a patient who has an ESR1 mutation, what non-endocrine alternatives are there to treating ESR1 mutant disease? I don't know what your thoughts are there.
So in general, I would consider ESR1 mutation as a resistance mutation to AI, but one could consider ER-directed therapies like elacestrant. Even fulvestrant plus everolimus would be a reasonable option for a patient with ESR1 mutation. I would prefer that over exemestane everolimus. Plus, later on chemotherapy, there's no evidence to suggest that the activity of capecitabine is different in ESR1 mutant versus wild type. So chemotherapy could certainly be considered in later line setting.
No, that's an excellent point. Another question that came up for Frederic is, you just touched upon this, but are there additional advantages to tissue biopsy over liquid biopsy?
First of all, you need to have tissue at what moment for some biomarkers, like looking at VR2 status, the hormone receptor status, and to see if you have changes and to see if your tumor is HER2 low. The advantage of a tumor biopsy, this is the guidelines. When you have a negative liquid biopsy, you should test on a tissue. But here, as those mutations are induced, sometimes if you are at the beginning of the resistance, you are not going to have a lot of cells with the mutation. So that's why it's better to do another liquid biopsy after 2 or 3 months. But the advantage of the tissue biopsy will be that you can really very well select area and have area relatively pure with tumor cells, where you can see the presence of other alteration and having sensitive data. But now in liquid biopsy with NGS or digital droplet PCR, we have extremely sensitive tests. So the technology is evolving extremely fast, and when we see what they provide at Guardant with this 360dx test, it's really amazing in terms of the number of genes they can cover. It's very interesting.
You bring up a good point that there are some things in the tissue that we do look at. One of those now coming up is HER2 low status, which we won't be able to get off the liquid biopsy.
Mm-hmm.
Maybe Aditya, you could tell us, how is your group thinking about rebiopsying tissue in the metastatic hormone receptor positive setting now with TDXD, and how do you think about placement of TDXD along your current treatment algorithm?
Yeah, you're looking at an excuse to actually find HER2 low disease. Our team recently looked at our experience in TNBC and found that in patients who had multiple biopsies, you have much more likelihood to find HER2 low, which makes sense. And some of this could be analytical variability. Others have brought up this point, like if you look at the same slide but give it to 5 different pathologists, you'll get different results. But the point is, if you find HER2 low for regulatory reasons, it's easier to justify the use of TDXD. So we look for an excuse, and if a patient does not have any documented evidence of HER2 low disease, certainly consider a biopsy. In terms of the algorithm, I generally do it once a patient is getting chemotherapy. So once you've exhausted endocrine-based options, generally once you've had disease progression on capecitabine, which is usually my first to-go chemotherapy agent, that is where I consider TDXD. So very similar to the label and what was seen in Destiny Breast 04.
Thanks, Aditya. I think we'll get a little bit more confused if DB06 is positive, as you know, you're very involved in leading that study looking at TDXD in the sort of post-endocrine therapy setting, really, in essence, prior to chemotherapy. So that will be interesting and could put a twist on all these. It just shows you how rapidly our algorithms keep changing. Frederic, do you get asked often by your colleagues to reread an old biopsy? Given the point that Aditya brought up about the issues of pathologists rereading.
That's what David Rim called persuasion medicine.
Right. Right.
Are you sure? Really? Just after this session, I have a training for pathologists for HER2 low, it's a webinar with the digitalized slides. I think that, yes, of course, they ask us to review the slides, and we have run different studies looking at biomarker evolution between different series of biopsies. What was said in the ESMO guidelines for clinical practice is that, in fact, you need at least to have one sample that was HER2 low, because we don't know exactly what is the biology behind that. Is it because we have multiple activated pathway in the cell, and that we have the receptor that is has a longer duration of life and staying longer on the surface of the cell? We don't know exactly. It's not a normal receptor. It's slightly activated. So yes, we have a lot of persuasion requests from going back to slides to look at HER2 low right now.
Oh, that is interesting. A lot more pathology work. So, Aditya, you did a really nice discussion of the data from Emerald. And I think we've seen some subset or subgroup analyses that have come out really trying to help us figure out which patients should get elacestrant. One of which was if a patient had very prolonged benefit on their upfront CDK4/6 inhibitor and endocrine therapy, they seem to do better with elacestrant and have a longer progression-free survival, for example, compared to those patients who may have been on their upfront CDK4/6 inhibitor for a shorter period of time. Are you using that information clinically currently in practice to select patients for use of elacestrant? So not just looking at presence of ESR1 mutation, but then looking beyond that at clinical course on first-line therapy?
Yeah, personally, it's a discussion to have with patients. If you look at the FDA label does not mandate prior duration of CDK4/6 inhibitor in terms of using elacestrant. So it's not something that I absolutely need, but it's definitely a discussion with the patient. These things also become more relevant if a patient has, say, dual ESR1 PIK3CA, when there are other options and you're debating other options. I think that's where these factors come into decision making.
And can I also ask, what about if someone has, Frederic brought up this issue about people having multiple ESR1 mutations. If someone has one, do you care which mutation they have? Meaning if they're, for example, 537S versus, D538G, do you care which ESR1 mutation there is to help make any clinical decisions?
Not at this time, because we've not seen any data to suggest that elacestrant is not active for any specific type of ESR1 mutation. So till we have data to suggest that the efficacy varies by type of ESR1 mutations, I'm not using it for decision making at this time.
Oh, that's helpful. I love this comment. Everything is so evolving so quickly. Could artificial intelligence help us a bit? I think given these complex algorithms, we definitely do need some help of fact, because I find it's complicated. I'm, again, trying to look at so many things, like how long were they on their upfront CDK? Do they have ESR1? Do they have PI3K? Are they germline BRCA mutated? Do they have an RB mutation? Or, really factoring in so many different things. I don't know, Frederic, is there, from a pathology standpoint, do you guys have any tricks, or how are you thinking about AI technology in the pathology world? Because I know it is rapidly evolving.
Yes, so we have now we are working with different types of AI. Some of them are helping us for for instance, evaluating HER2 low or counting percentage of ER positive cells, and then you have deep learning studies looking at an H&E slide and predicting the likelihood of germline BRCA or PIK3CA mutation. So this is things that are moving and moving. It's not ready for prime time right now. For ESR1, it will be different because it's induced. So you cannot maybe you will be able to predict, I don't know, but for the moment, I don't see how could we predict that from the H&E slide from the primary tumor. But for BRCA, we have now some algorithm that can predict a very high possibility of having HRD or BRCA alteration in breasts, around 92-93%. So pre-selecting patients for germline testing, for instance, that could be very interesting for triaging patients.
Yeah, that's great. And I guess I'll turn this question back to you too. What about TILs and ER-positive disease? We are starting to think about TIL, particularly in early stage triple negative breast cancer, where it does seem to be prognostic and particularly may also predict if there's some patients who could potentially get away without chemotherapy, those small stage 1 triple negatives with very high TIL. There's certainly prospective work being planned to look at this. What do you think the role is of TIL in the ER positive setting?
So in ER, it's very different. We have, because the population of TILs are different, the level of TILs are different. Also, there are usually lower level of TILs when you compare to HER2 positive or triple negative breast cancer. And some studies have suggested, for instance, that high level of TILs in an ER positive breast cancer would be the opposite, so would be a marker of a poorer prognosis. So we have a lot of things to learn from a more precise evaluation of what type of TILs do we have, what are the role of macrophages or eosinophils or polynuclears that can be also present. So it's very different, and it's completely different from triple negative breast cancer.
Yeah, it's interesting. There was that presentation at ESMO Breast that had, just like, as you said, showed that high TIL and ER-positive disease was a bad thing rather than a good thing. Whereas at ASCO, we saw data in young women with TIL suggesting that high TIL predicted better outcomes, right? So I think we're seeing very discordant data, whereas as you point out, in triple negative, it's been more consistent, suggesting that high TIL is a very good thing. So I guess we'll have to learn more.
Yes. For breast cancer is much more heterogeneous than we thought at the beginning. So that's probably why we have so discordant data, and also different data when you would look at young women and postmenopausal women.
It's very interesting. Well, this is a great question that came up too, and I don't know the answer to this. I don't know if Aditya or Frederic, it says, is racial disparity observed in ESR1 mutations? Do you know if there's...
Not for the moment, to my best knowledge. I have not seen that. Probably we will have data coming soon with the generalization of ESR1 alteration. Maybe we will have more data of prevalence of certain alteration in certain population. But right now, we lack data on that.
Thank you. That's helpful. Well, maybe because I'm curious about this question, Aditya, how do you think about continuation of CDK4/6 inhibition beyond progression? Obviously, your group had done a lot of work looking at abema in this setting. Is it something that you're currently doing? And if so, for which patients do you think about doing it in?
In general, we do think about continuing CDK4/6 inhibitor, especially if a patient does not have actionable alterations. So considering fulvestrant plus abemaciclib, in general, our practice is to consider ribo or palbo in the first line setting, and then at the time of disease progression, abema, because it does appear to be a bit different from the other CDK4/6 inhibitors. But very eagerly awaiting the results of post-MONARCH, which will definitely address this question because it's looking at fulvestrant plus minus abema in the second line setting. I'm curious about your practice as well. Do you continue CDK4/6, and what's your practice in the second line setting?
Yeah, it's a good question. I will say I've used it in very select patients. So, you point out if someone doesn't have a PI3K pathway alteration, for example, so isn't a candidate for that type of pathway inhibitor upon progression. I also, and I don't know if you look at this, but I make sure they haven't acquired an RB mutation. So I'm getting a ctDNA panel anyway at time of progression. I want to make sure they're PI3K wild type. I factor in if they have an ESR1 mutation. But then if they just had a tiny bit of progression, so, those patients who have like bone only disease, and then there's one little spot in the bone that looks like, well, maybe it sort of progressed, and it was someone who was on their upfront CDK for a really long time. So you're not really looking to change, but kind of feel obligated because there's a new bone spot that they're asymptomatic for. That's kind of the person that I'm ideally thinking about continuation of CDK4/6 in. But it's kind of that select patient here. I don't know if you look look at any genomic characterizations to help you figure that out.
Interesting thought, because that would confer resistance to CDK4/6 inhibitor, and that has been seen. It's not very common, but it is an acquired alteration similar to ESR1. So that's a good point. And in general, we do panel-based testing at this time. Just looking at ESR1, PIK3CA, you're looking at multiple genes. So you get that information. Not that you were looking for it, but you get that information. So it's tough to ignore it.
Yeah, no, that's helpful. And if you do continue a CDK4/6 inhibitor beyond progression, can I ask which one you use, and does it matter what they got in the first line setting?
Yeah, in general, similar to endocrine therapy, I'd like to switch the CDK4/6 inhibitor. So usually abemaciclib is something I consider in the second line setting.
It's tricky because, given PACE and Palmyra, I would say I'm not comfortable with palbo post-palbo. But given Maintain and certainly your Abema series, it makes one think if they got palbo up front that they could do ribo or Abema. I think the challenging issue is that we're now switching kind of to most people getting upfront ribo as their first drug. And so that will pose an issue about what to switch to upon progression. And I guess, as you point out, we really do need more data here, and hopefully post-Monarch will help address this so that we can understand if Abema is the right choice. Well, this is a really helpful discussion. I guess in terms of other questions and things that come up in this setting, when are you turning to chemotherapy as opposed to trying another line of endocrine therapy? I think this is a tricky thing. I think I find that people don't last as long on endocrine-based therapies as they used to now post CDK4/6 inhibition. So I do find myself moving often to chemotherapy after just 2 lines of endocrine therapy. I don't know, Aditya, if you find something different or you're able to do better than me.
Yeah, I would disagree. I don't think so. But in terms of, I think, algorithms, that's where it's tough to do an algorithm, because you have to look at the patient and their pace of disease. If a patient has disease progression, say within the first 12 months on a CDK4/6 inhibitor, that's the type of patient you worry probably has more endocrine resistant disease and will get chemotherapy early on, maybe second or third line, versus someone who's on AI CDK4/6 for 5 years and then say fulvestrant, alpelisib for 14, 16 months. So that's more indolent in terms of biology. So I would like to continue endocrine-based therapy for that patient. So it's more based on the pace of disease, the site of disease, but in general, like to exhaust endocrine-based options before going to chemo.
No, that's super helpful. Well, I'll turn, I think we're out of our time for our discussion, but we did want to provide a few clinical takeaways. So Aditya, I'll turn it over to you to summarize some takeaways from this presentation today.
Yeah, no, thanks so much, Dr. Tuleni. That was excellent moderation. We had a very robust discussion, and we see this in the chat as well. Thanks for your comments in terms of discussion and for all the questions. To summarize, this was great discussion. The key takeaway points are that elacestrant is the first oral SERD to be FDA approved for postmenopausal ER-positive, HER2-negative patients with metastatic breast cancer who have detectable ESR1 mutations. The FDA approved Guardant 360 as the companion diagnostic to identify ESR1 mutations. In the future, there are other oral SERDs in clinical development which would change the treatment landscape, either alone or in combination with other therapies like PI3 kinase, AKT, mTOR inhibitors. It's important to understand genomics because genomics can dictate the type of therapy. For example, for PIK3CA mutation, use of a PI3 kinase inhibitor, ESR1 mutation, use of an oral SERD. ESR1 mutations are acquired alterations, so they can be identified by liquid biopsy at the time of disease recurrence. Thank you again for participating today. I would like to thank the panel members for the participation and excellent discussion. And we look forward to the future studies, particularly Persevera, Serena 6, and Amber 3, which will look at different oral SERDs in the first and second line setting, and also address some of the data gaps we've been talking about. The role of CDK after CDK4/6 inhibitor is the role of monitoring by ctDNA and changing therapy based on that. So look forward to continuous discussion, and hopefully in the future we'll have a similar session when we can address these data gaps with newer data. So thanks for joining today.